Okay, thank you everyone for tuning in. I'm so excited to be here with the midwives of Tourmaline Birth and Wellness Collective. And I just love your guys' philosophy on birth and the way you look at birth and you honor families and birthing people so much, and I love that. So I wanted to do this video as a way to introduce you guys because the birth center is just opening up and it's so gorgeous and you guys have worked so hard. I'm so excited about it. But also because there's a ton of fear around birth already, and then add the pandemic to it. And then also on top of that, add news stories that get publicized and media and things like that really play into people's fears. So there are a lot of people who have changed their birth plans because of this pandemic, and people considering birthing out of hospital, probably more now than ever. And there is a recent story about one of the, I don't watch the Housewives, but one of the housewives, I believe in Orange County, who chose to have a home birth and lost her baby. And it was a very tragic story. And, you know, it was all about shoulder dystocia and a brain injury eventually leading to the baby's death. So I watched her interview on Good Morning America, and it was so devastating. And unfortunately, I think that is now kind of like a headline story that's turned into like home birth, you know, could have been avoided, baby died. Mm-hmm. So I wanted to get your guys' perspective because I know you guys are so well trained in this, and you guys have a ton of knowledge when it comes to this. And we have all had conversations about this lately. So I wanted to just have you guys share some facts, a little more information about what shoulder dystocia is, and things like that. So why don't we do a quick intro of who each of you are, just your names, and then we'll go into more of the shoulder dystocia info. So Josie, do you want to start? Just introduce yourself.
Hi.
You're muted. There we go.
I muted myself. I'm Josie, and I'm a licensed midwife at Tourmaline.
And you were my midwife as well.
I was honored to be at Steph's birth.
I love it. Allison?
And I'm Allison Tartari. I'm a licensed midwife here at Tourmaline Birth Collective.
And Moral.
Hi, I'm Moral Shabak. I'm also a licensed midwife at Tourmaline.
Excellent. Thank you. So why don't we first start with, let's actually start with midwifery training, because a lot of people think midwives are kind of just winging it and like doing these home births or birth center births without technology and without proper medical care. So why don't, if one of you will explain a little, just a short blurb about what it takes to be a midwife and your clinical training with it.
Yeah, so midwives do a lot of training before getting licensed. So we have our didactic education, which on its own is 3 years long. And then most of us do simultaneous preceptorships while we're doing that 3-year didactic education, which includes just about everything you would need to be a midwife. So we get education on medications, all of the preventative care we need to do, lab testing, all that fun stuff. And then we do, our full-time preceptorship simultaneously, which means that we have a midwife or a group practice that we're working with us students, and we're with them full time. We're on call when they're on call, we're attending appointments, we're going to births. And we have several tiers that we move through in that role of being a student. We have our observed births, our assist births, and then our primary births. So even before we get licensed, we attend 25 births where we're the primary midwife under supervision. So, that kind of ensures that we know how to manage a birth on our own long before we have our license and the ability to do so. And our minimum requirement is 2,000 hours. And most of us end up doing close to like 4,000 to 5,000 hours of clinical training before we even sit for our massive exam. And then we take our NARM, which is a 6-hour-long medical exam. And then we become licensed by the Medical Board of California. Mm-hmm. And California has its own specific law. So the midwives here are licensed midwives. That's our state-specific licensure. And then we're also CPNs, which is actually an international license. And that's given by a NARM. So, we have a lot of knowledge and a lot of training, and most importantly, we have a lot of hands-on training.
Mm-hmm. So it's very similar to chiropractic in that you have these large associations that kind of oversee your education, and you end up with a license to practice what you do. And so a lot of people ask me, especially with the birth center opening, they go, so is there going to be an OB working there overseeing everything? And the answer is no. Because you don't need an OB, right? You have your license to take care of people the way that you need to take care of them, right?
Yeah.
Yeah.
Yeah, and part of that stuff is that we serve a healthy part of the population. So we're looking at healthy, normal, pregnant people.
Yeah.
And we do a lot of nutritional counseling, looking at emotional, social, physical ailments, and using holistic things most of the time to keep people within normal and healthy. And then if a pregnancy falls out of that, then our refer is to an OB. Mm-hmm. So we get really good at knowing normal.
Yes. And so as a midwife, you're trained, and basically what you're saying is that you know what's normal and what's a normal, healthy person that is sort of, what's the word, like eligible for birth. Low risk. Yeah. Thank you. Low risk. Yes. Okay. So let's jump into a little more of this shoulder dystocia story. And, so again, I don't want to go too much into the details of this particular birth because none of us were there. She's not any of our patient. But it's definitely a story that's making headlines. So let's first start with what is a shoulder dystocia? You have to take that one.
Josie.
A shoulder dystocia, basically it's when the shoulder is impacted either on the pubic bone or the sacropromontory. So as the baby's rotating out, the head is born, but the shoulder is hung up. Mm-hmm.
So it's basically the head is out and the baby's now stuck because the shoulders are stuck, can't rotate or turn somehow. Mm-hmm. They come out. Mm-hmm. That's right. Okay. So now this particular case resulted in some brain damage. And so Allison, do you want to talk a little bit about that? Because we discussed that a little bit a few days ago. Because the story that's out there is that the baby was stuck with the head out, didn't get oxygen to the brain, leading to the brain damage, leading to the baby's death. Do you want to share a little bit about that? Remember, we were talking about when that event usually occurs.
Well, when it usually occurs, there's different risk factors. It can be, this particular baby weighed 11 pounds, which they were not aware of. So large babies are more at risk of a shoulder dystocia. There's other risk factors, but when it usually occurs, you never know. That's the thing with the shoulder dystocia, is it's completely unexpected besides those risk factors, which, what are all the risk factors, Maral? It's if they have gestational diabetes, a large baby.
Yeah, and then of course, if mom has any anatomical issues. But for the most part, it is, really difficult to predict. And I think, Steph, what you were hinting at was we were kind of talking about the moments at which the oxygen deprivation could happen. And it's really difficult to get a clear picture, right? So we do know that when baby's head comes out, that of course oxygen deprivation kind of starts to happen, because we know that the umbilical cord is being occluded just by the bones of the pelvis, and ligaments as well. But it is really difficult to know if there were other stressors on that baby that happened in labor and even prenatally. So it's really impossible to know exactly what that whole picture looked like. And, as midwives, we are trained in resolving shoulder dystocias, of course, as quickly as possible. And we are aware that there's a running time clock. So all of our strategies and maneuvers are kind of dependent on how much time has passed, what baby is looking like, and we modify the procedures that we use to get that baby out based on how we feel like that baby is handling having their head out with their cord being occluded.
Yeah.
That is a training that we do consistently several times a year. Like, we just signed up for another class that's going to be taking place, an online spinning babies class in shoulder dystocia. And it's something that is a little bit unique about midwives, because doctors are trained how to handle that, but it's something that we revisit over and over and over to make sure that we know how to handle it. Because in hospital, shoulder dystocias are handled pretty much the same way they would be out of hospital. And there's not one place that is safer for a shoulder dystocia. The outcome really just depends on how, like Maral said, how quickly the baby comes out. But the difference in midwifery, right, our training in obstetrical care is that they're trained in surgery. But with the shoulder dystocia, there's really very, very few instances when a shoulder dystocia would be resolved with surgery, mostly because of time. The amount of time. By the time they know there's a shoulder dystocia and the baby's there to use that maneuver and get it back up and take it out with a cesarean, it's very rare, and it can be even more dangerous. So there's not a way to tell that it's safer to deliver in the hospital out, compared to out of hospital, especially when it comes to shoulder dystocia, because it just happens.
And you don't know until it's happening, right?
Once it's happening, there's no, you can monitor the whole time. You can monitor the entire time, and it can be perfectly fine.
So we know
until you see signs like turtling, or you see the baby's head out and then there's no other no other movement, or if there's a change of color.
Exactly. And there's things that licensed midwives do in just common practice to reduce the incidence of shoulder dystocia, just by allowing moms to move intuitively and encouraging moms to move intuitively and to use their body, and that if they feel like a position is uncomfortable, to go to that position where they feel like they're working with their body and their baby. So also, like, when a woman is complete in our practice, and this might not be all midwifery practices, but just because you're 10 centimeters doesn't mean that you're ready to push. And so one of the things that can cause a shoulder dystocia is if you've got pushing happening before that baby's made that rotation, right? So also another thing that is really good to look at is, like, I know that part of this story is, like, she came in late to care, and any time with midwifery care, one of our benefits is knowing our clients and connecting with them and them feeling safe with us. And I can't stress that enough how important that is, and it's so fundamental. But, like, if I'm tensing up stuff and you're gonna give me an adjustment, I'm gonna mess up my neck or back or sacrum or whatever you're adjusting, because I don't have that trust. So, and it's the same thing with midwifery. If you're pushing your baby out and all of a sudden you're not comfortable, or you're fearful, or so.
Right.
I'm sorry. Go ahead.
I was going to say another interesting fact about that particular case is, like I said, the baby weighed 11 pounds, which they said was not known. In midwifery care, every time you come in, the first thing we do is introduce and ask, if it's okay to touch your belly and to feel baby and what position baby's in. And you can feel the baby as it's growing. We measure as well, but touch is so important. Besides what Josie was talking about, interacting and connecting through energy, touching the baby, you get facts through that. That's why we're doing it. It's not just to feel a baby. We're collecting information that is beneficial and that can be preventative. If we know we don't, and most midwives don't have an ultrasound machine at their disposal. We utilize those things when needed, but we don't have one here. So we go through touch, and many times we're like, hey, we don't understand exactly what's going on here. If we think it's a breech baby, then we will utilize that. We will send someone out. But touching is so important to gather that information.
And that's one thing that I've noticed is I feel like midwives are really skilled at palpating and feeling the baby and getting a pretty close estimate at baby size.
Mm-hmm.
And maybe in this particular case, because she transferred late to care, maybe her providers didn't have as much of that time to palpate, like see the growth of the baby. So maybe that was something that was potentially, I don't want to say missed, but
Yeah.
But no matter what, wherever she delivered, it very well could have been the same outcome. So that's, I just was bringing up the importance of touch and getting to the point.
I know another portion of this story was there was a lot of criticism for that client not having ultrasounds in third trimester, which ultrasounds in third trimester are not accurate for
sizing.
Yeah, because you're not able to see the whole baby in the same image through ultrasound. So you're adding up portions of one body and hoping that it's correct. And it's, versus where we use our hands, like you have that whole baby in your hands. And of course, that's not an exact science either, but I think it's just incorrect to say that an ultrasound would have predicted that this was a large baby. Now,
yeah, and an ultrasound's not going to tell you when the shoulders are stuck, right? Because you wouldn't be ultrasounding as you're pushing, right? So an ultrasound probably would not have predicted this anyway.
Yeah,
right.
And an ultrasound in third trimester may have led to a provider saying this is a large baby, but that happens a majority of the time, regardless of if it's actually a large baby or not, because there is fear around this large baby, right? So a provider that's doing an ultrasound is almost always going to defer to indicating that this baby is larger. And we see that all the time where it's like, oh, this is a 10-pound baby. And then the baby's born, we're like, oh, like 7.5 pounds.
Right.
So
another really good fact, I'm sure all of you have attended mini births with babies that are over 10 pounds and they come out. And then I've been at a shoulder dystocia when the baby was less than 7 pounds. So
sizing isn't necessarily a predictor.
No, we have big babies. The average size of a baby is always larger, or the majority of them are larger out of the hospital. So midwifery care, our babies are bigger. We're not inducing, so we're not trying to get the baby out earlier. They put on a lot of towards the end.
Yeah.
Pregnancy.
So
and have babies all the time.
Yeah.
And this is another part of the picture with the late into care situation, right? So what makes midwifery care possible is we do so much preventative care. Mm-hmm. That's how we guarantee that our moms are healthy enough for an out-of-hospital birth where there is not an OR next door, or forceps or vacuum or whatever. And that's why we do so much nutritional counseling, and we offer like monitoring of at-home glucose readings, and we assess risk factors for those things. And if we can guarantee that a mom is having a good diet that works for their body, works for their system, then if that mom grows a 10-pound baby, then that was the size baby that she was meant to grow.
Yeah.
So whether she's really tall or her partner's really tall, right, we can be certain that it's not because of a glucose imbalance that led to a baby that's
right
too large for her body to birth comfortably.
Right.
And we're certainly not saying that this midwife didn't do that. Like you said, we weren't there. We don't know the situation.
Right.
We don't know what kind of care she gave.
Right.
So we're not saying that she did not do that. We're just letting you know how it would be handled.
Yeah, it's hard, Steph, because in birth, there's always this element of life and death in birth, because
it's just the nature.
That's just the nature of birth. And so as midwives, we are trained to deal with obstetrical emergencies that can occur in birth. But, this mom could have been doing all the right things, right? She could have been doing everything correct, and she could have given birth in a hospital, had a shoulder dystocia, and still lost her baby, because that's just the element of it. And we see that on the other element. Like, she could have had a cesarean section and still lost her baby. Like, there's just an unknown, and we don't have the control over that. And so it's really sad, because I feel sad for the midwife, I feel sad for the family, I feel sad for my midwifery community, and all of our pregnant mamas right now that are like now getting this frustration of anxiety and fear about birth with this story.
Right.
And the rate of shoulder dystocia is very low. It's like what is it? 0.2
to 3%, right?
Yeah. So it's a very low percentage. And most of the time, the shoulder dystocias, the shoulder can be freed within 2 minutes or so, right? So, it's just unfortunate.
Yeah. And I know this particular family lived only 4 blocks away from the hospital. So, it's, I don't know, I feel like it's not like she was doing like an irresponsible thing by like having this home birth. And I feel like that's what some of the news stories are making it sound like. So let's talk a little bit about what would be the typical like procedure in hospital with a shoulder dystocia, and what would be the typical procedure from a midwife.
Can I say something really quick just about what you're talking about, where she lives?
Yes, please.
Where the hospital is? It's something like, even that would never, being 4 blocks away or being in the hospital, most people, if you're considering an out of hospital birth, the most important thing to do is to educate yourself and look at the rates. The United States has very high infant and maternal mortality rates, sadly, in developed countries.
Yeah. So
we don't have a great reputation. We don't have great numbers in hospital. So it's kind of, just thinking that you're safe going into the hospital is probably more traumatizing when something like this happens, because, and then it's hard because we love doctors. We refer clients out if it's a client that we don't feel is appropriate for midwifery care. We definitely aren't going to try to be the savior and treat someone that shouldn't be here. Right. But the statistics show that their babies die in hospital. We don't have great rates here. So doing your own information, actually checking into the hospital that you plan on delivering it. You can call Mary Birch anywhere around here and ask what their cesarean rate is. You can find out what their death rate is. You can find, when you're going to work with a midwife, you should do the same thing. You should get to know where you're delivering, who's going to be there attending your birth, and what their statistics are, and just like you were asking, what their education is. But a lot of people go into the hospital just thinking, oh, it's a hospital. Well, there's doctors, and babies die all the time. We've all experienced a baby die in hospital or know someone that has, and it doesn't go on the news. That's the difference. She would not sit there if it happened in the hospital, because the nurses and the doctors would have had a reason why the baby died. Even if it was a shoulder dystocia, they would have. The media likes to switch things around. This is out of hospital, so it's more or it's more controversial. Right. So we don't see every time. I mean, how many more? We're only 2% of the community delivers outside of the hospital. Mm-hmm. So the majority of babies are born in the hospital. We do have these statistics. Can you imagine if every time a baby passed away, it was on the news? It would be overwhelming. Right. It wouldn't want to hear that. But when it happens out of hospital, and that would scare me too. I totally get why moms are thinking that way.
Especially with someone who's famous.
Right.
And it really makes the news.
Yeah.
So let's talk a little bit about maybe just briefly what the difference would be to resolve a shoulder dystocia, both in hospital and out of hospital.
Yeah, so I try not to make it too like detailed and medical, but as far as the midwifery side, we do, like Josie touched on before, we do a lot of education on how to release those shoulders. So the main thing is, if we're going into assist a baby and coming out, we're never going to pull on the neck or the shoulder because that brachial plexus can become damaged. And as we know, that can lead to a lot of lifelong complications for baby. So the general rule of thumb is you want to, get mom into different positions that help open her pelvis. One that people are familiar with is runner start, and that gives more space. And oftentimes baby will just come out just by getting mom into that position without the midwife having to use her hands internally. And then the next tool is, we try to reach in gently, and sometimes we're able to just nudge the shoulder. It's more common to have a shoulder that's stuck on the pubic bone than the sacropromontory. So usually we're able to just go in there and do a rotation of the shoulders and have baby come out. If we're ever needing to, I don't want to say pull because we never really pull. If we're needing to give some traction, we try to go in both sides and have hands on the front and the back of baby's body so that we're not disrupting that neck or tugging on that neck.
Yeah.
And of course, there's a lot more, nuance and detail to all these maneuvers, but I won't bore you guys with that right now. And as far as the hospital, I know that just in general, I don't want to put everyone under this category. There isn't as much training around these small movements. One reason for that is a lot of people have epidurals in the hospital. So getting into like a runner starts with hands and knees is not an option to begin with. So we've, higher percentage, we've already lost that portion. For us is the first step and usually resolves most of our, if there's a shoulder dystocia. And generally in the hospital, they are going to do downward traction on the fetal head. And that's, still in most obstetric texts, that's the go-to is to just begin that downward traction, which we, of course, know can lead to all that damage. And then you don't really have a step.
And it doesn't help get the baby out.
Yeah, because it's not the neck. It's not the head that's stuck. We have an impacted piece of bone on a piece of bone. You're not going to magically break through that. Right. And then the final step, the last go-to in hospital or home birth or birth center birth is to break the clavicle because then that reduces the diameter and baby can be born. And of course, easier said than done, right? So, so the big difference, as you can see, is midwives, we have 12 steps we can take in between traction on the baby and breaking the clavicle. And that's the biggest difference. We try to do our like slightly non-invasive tools first, especially because they are also the most effective.
It's so interesting because I remember, when I had Aubrey, my first, when I was having a home birth and transferred because it was a really long labor and I was in a lot of pain and I decided to opt for an epidural, which wasn't the plan. And I already didn't want to birth in the hospital, but there I was. And the obstetrician who was on call said to me, which how on earth they are allowed to say things like this, but said, she palpated my belly, and I chose not to have any ultrasounds during my pregnancy. Luckily, my midwives were okay with that because there weren't any other risk factors, and it was medically okay to do that, and it was my choice to do that. But she said, your baby is at least 10 pounds. You're not going to be able to push the head out. If you do, you won't get the shoulders out, and I won't help you with vacuum or forceps, and your hips are too small. And I was like, lady, I am not a size 2, first of all. Hips are plenty big, especially then. And Luckily, there was a shift change and a new doctor came in, and lo and behold, my baby was 7 pounds 3 ounces, not 10. And luckily, I think because she said your hips aren't big enough, and I was like, oh my God, lady, you need your eyes checked. My hips are huge. Because I was like, okay, now I don't believe anything you said. And that's not evidence-based. And yes, I will be able to push my head out. And now you're just trying to scare me into a C-section. But could you imagine, Allison, like you said, and Maral, you said it too, educating families on the type of care and providers and things like that. Had I not been educated, I would have just been scared. Oh my God, shoulder dystocia. Of course I need a C-section, you know? And so I think that happens quite often. And I think there are probably a lot of providers who are really afraid of shoulder dystocia, especially now when a story like this comes out.
Definitely.
For sure.
I taught shoulder dystocia last month or a couple months ago at Najoni at the midwifery school. And in my search for giving students examples and resources, there is so much fear about it. Don't YouTube shoulder dystocia. It's full of fear. And yeah, it's insane.
Yeah, I think just overall, it's like fear is the key issue, right? So even with our interactions with OBs, there are plenty of OBs that just get it. Like, yeah, birth works. I'm just here to do the things that I need to. And if someone's high risk, there's plenty of those OBs. And I think the ones that we get that were like, oh, you're saying a lot of not evidence-based things, they're also working from a place of fear.
Yeah.
That's twofold in that they're not trained in for natural birth.
Right.
So I would be afraid too if I was being thrown into a situation where someone was asking for something I don't have a lot of training in. That would scare me. Or even, you know, having a mom, which of course this doesn't happen with midwives, but if a woman walked into this facility in labor right now, I would be very tempted to like do a lot of things. You know what I mean? Because you're like, I don't know your background. And I am working from a place of fear. And that's why midwives don't do that. We don't take people in labor. We don't have the tools. We don't have, you know, that's not what we do. And, you know, not just, I don't want to justify the actions of OBs that try to put fear in their clients, but they have this inkling of fear in themselves, and then no one stops them from putting that on to their patients and clients.
Right.
That's the thing.
I think that's really the magic of midwifery, is that you establish such a bond and a trust with your birthing families that when it comes time to labor, you know them so intimately that it just creates a much more like synchronistic event. And there's less intervention that you have to do because, like you said, birth works. And I know we were talking the other day to Allison, you said something about like usually when there is lack of oxygen to the brain, it usually occurs before the pushing phase. Is that right? Is that what we were talking about? Do you remember?
No, we're talking about like a hypoxic event.
Yeah.
That it can take place before, so you might, but you don't always know. Like,
but yeah, and
so it's possible, I'm just assuming here, it's possible that maybe in this particular case, maybe the baby died because of the event that was not even related to the shoulder dystocia. Is that possible?
I mean, anything is possible. It's hard to know, right? Because we do, all midwives will like take heart tones, and our ears and our counting abilities are trained in picking up patterns that indicate a hypoxic event is happening or has already happened, and now we have a baby that's just trying to maintain their levels. Anything is possible, but I feel like we can't comment on that without having like the medical records. You know, if they were getting heart tones that were great and showing like good variability and like super normal, then it's probably unlikely that we had 2 hypoxic events before that case.
No, the reason I had brought that up, Sophie, I know what you're talking about, is because I said, again, I feel weird talking about this because we don't know the midwife or what she did, but she showed up in the pushing phase. So we don't know what happened prior to that. We don't know if the baby was suffering. It was only a doula with her, as far as the story reads. You know, I don't know this.
Right.
I don't trust everything the media writes.
Yeah.
So I kind of feel weird talking about a birth story that I have no idea firsthand But that is what they're taught, the midwife, which families do sometimes choose to call later. I mean, it really is ultimate. You can't force someone to call you or to allow you to come. So I don't know why she was there later. And then the mom also mentioned that she lifted her leg. In the interview, she says that she lifted her leg and the baby came out as the paramedics were walking in. So it's just, there's so many unknowns in that whole situation. And there's no way to explain this. But there is a way for people to educate themselves, find out statistics of both in and out of hospital births, which I think is the most important in this whole reason that we're discussing this, is that people understand that just because this well-known person and on TV, shared her tragic story, that it could look bad on the entire midwifery or out of hospital birth community, because that's not statistically true. So
Merle, were you going to add something?
Yeah, I was just going to say, because we kind of talked about procedures and what we do for shoulder dystocia, we can't know if it was 6 minutes into the shoulder dystocia that lifted her leg, but that would be really uncommon for a midwife to not encourage a position change immediately.
Yeah.
So, we could have had a shoulder dystocia that did resolve within 2 minutes. I can't know that. And then if that is the case, well, we didn't have oxygen deprivation from that shoulder dystocia then.
So that's there's so many elements. It's like, what was going on during the labor? What was going on during the pushing phase?
Yeah.
We can't really speculate too much.
Right.
We can only, we're all gonna study up on our shoulder dystocia and do, we do drills here at the birth center. So we'll do our drills and make sure that we're prepared. And also we can let our families know too. A lot of times when we do like what we call the home visit and home birth, when we do that kind of, what are we calling it? The birthday prep visit?
Yeah.
The birth of the baby. A lot of times we mention, like, if I ask you to get out of the tub or if I ask you to switch positions, I want you to be able to do that. And we'll have moms kind of practice that. Like, how does that feel in your body? So that we're not coming from a place of fear when we change your position. And that we can not react, but that we can act calmly and help.
Right. Not from a place of panic.
Yeah.
I didn't ask you guys this before, but have you each been to a birth with a shoulder dystocia? Have you seen it?
Yeah, so it's interesting. So shoulder dystocia, there's kind of like a 2-tier. Sometimes we call them sticky shoulders when they resolve really quickly without too much intervention. And then true shoulder dystocias, again, they are so rare. And so I personally have probably only attended 2 true shoulder dystocias in like 6 years of doing this work. Actually, 3 in 6 years.
Which is, like, statistically that makes sense, right?
Yeah. Matches up.
Yeah. Yeah. Interesting. Okay. Anything else you guys want to add about this story?
No, my heart goes out to everyone involved.
Yes. It's definitely a tragic story, and my heart goes out to the family, and it's definitely a tragic loss. But I think the take-home message that I want to send to everybody is just, empower yourself, prepare yourself, connect with your care providers, and birth where you feel empowered.
Yeah.
Right? Birth where you feel empowered.
And ask them comfortable questions too.
Mm-hmm.
Because you gotta do it.
Yeah.
It's important.
Yeah. And also, don't make decisions out of fear in either direction.
Right.
If you're choosing a home or hospital birth because you are afraid of the hospital, that's still not a good reason to choose home or birth center. You have to choose those things because they're where you want to be versus where you don't want to be.
Yeah.
Right.
if you're choosing to birth, and we had a meeting, like us midwives had a meeting before this happened, because we knew that we would have people calling and trying to transfer. And I specifically in the beginning, I'm like, I don't feel comfortable being a doula for years, like attended hundreds of births. And it's like, if someone is leaving the hospital because they're scared to come to a birth center, they're not comfortable here. They don't feel safe. They're trying to leave what is scarier to something that is still scary. Their body's going to react in the normal way that it would if they were they probably would be safer in the hospital.
Yeah.
Not because they're in better care or because of but because simply their brain is allowing their body to open up, and it's not in that fight or flight, like scared, protective mode. So we do have people that are interested in birthing out of hospital, but we are interviewing each one and taking it case by case and having very long conversations about their education, because it's also important for them to educate themselves and take childbirth education classes specifically for out of hospital births, because it's a very different environment. Yeah. Not everyone is prepared for that.
I love it. Okay, great. Well, thank you all so much for doing this. I was hoping we could do a little bit more of like a fun introduction, but this story did come up, and I'm really thankful to all three of you for addressing it and answering the hard questions, because it's certainly a tragic topic. But I really, really love and appreciate your guys' philosophy around birth and how you take care of people. I think is so, so beautiful. So thank you so much.
Thank you.
You're the best neighbors ever.
Ditto.
We look forward to meeting all of your wonderful clients.
Yeah.
You have an amazing community. We've only met a small percentage, so.
I know. I can't wait for us to have big parties again.
I know.
Okay, so if any of you watching have questions for the midwives, you can find them at tourmalinecollective.com. I'll post the link in the comments, tourmalinecollective.com. You can also follow them on Instagram. Instagram handles Tourmaline Collective?
Yes.
Yeah. Okay, Tourmaline Collective.
If you have questions for the midwives, email at us at midwives@tourmalinecollective.com too.
Beautiful.
We're happy to answer any questions.
Awesome. Okay, great. Thank you, guys.
Thank you. Have a nice day.
You too. Happy birthing.
Thank you. Bye.